Whitney Jones. I'm the founder of the Colon Cancer Prevention Project and a gastroenterologist here in Louisville. And I'm going to be giving a little talk about early age onset colon cancer. This is a repeat of a talk I gave at the Iowa Cancer Consortium earlier this month. And we're going to run over it for the Colon Cancer Prevention Project and see if we can glean some salient points. So the title is Early Age Onset Colorectal Cancer, Implementing Action While We're Solving the Puzzle. Because that's a theme that you do not have to understand everything about a problem before you can begin to address it. The learning objectives are to understand the evolving features of early age onset colon cancer, including demographics, racial, anatomic issues, pathologic clinical outcomes. We're going to talk about the known and proposed causes for early age onset colon cancer. And the short thing is we don't know all about it yet. Third, we're going to discuss the major clinical challenges that lead to delays in diagnosis, which can be deadly and certainly decrease patient positive outcomes. And finally, we'll explore options to expand the continuum of colon cancer prevention to the under 50 age group. About 15,000 people will be diagnosed with early age onset colon cancer. And I always like to bring to rural countries or rural states the importance of that relative to other diseases we fight. 74 people worldwide have died from mad cow disease, but every single person in the world knows about mad cow disease. We've put policy into place about how to protect us from mad cow disease, and it's worked great. But again, 15,000 people this year alone in the United States versus 74 people worldwide ever. And so that's a broad spread, and it just lets me know how much more room there is for increased awareness and education around this. So early age onset colon cancer isn't new. It's been written about for years and years. There are articles back into the 70s and 80s about people in their 20s and 30s who got colon cancer, which was really thought to be a disease of older people. So it's not new. What we're going to talk about today is that it's just increasing in its volume as a percentage of colon cancer. So it's not the newness, it's just the rate of increase. So that's an important piece. It's not new. But if you look at the top 5 cancers under the age of 50, for men, colorectal is the #1 cancer incidence for men under age 50. Normally under 50 we think of testicular cancer as the most common issue for men, but in fact it is now the #1 colon cancer. For women, it's 4th behind breast, thyroid, and melanoma. But in terms of death, it's 2nd for men and 3rd for women. So it's not only a common problem, but it's a deadly problem. And this is shadows to some degree what we see in the over 50 population. But certainly we don't see the more incidence of lung cancer and such being nearly as high. So it's hard to believe, but colon cancer is a more common cancer than lung cancer in this population. The colon is an amazing thing. It basically takes 2 liters of fluid from what you eat and what you drink and how you process it, and it takes 2 liters of fluid out of your colon and then compacts the waste product so it can be evacuated. So as you go from the far right colon down to the left colon, everything that's not been absorbed gets concentrated further and further and further. And that's important in early age onset colon cancer because the vast majority of cancers are in the left colon, sigmoid and lower colon, and the rectum. And the rectum particularly is involved. So whether or not there's some component where the concentration of something we're eating, what's called the exosome, you're breathing it in, you're swallowing it, it's in your food, something that you're eating that's not getting absorbed, being concentrated further and further as it goes down your digestive tract, is an appealing line of reasoning as to where this may be started and how it may be going. So, because it's important that even though colon cancer in the left colon is going up and rectum, it's relatively stable in the right side of the colon. So this is a left colon problem in the early age population. So the incidence trends overall, and again, I don't know if you want to zoom in on this, but if you look at just sort of the big picture, we've had declines in colon cancer 3% per year, colorectal 3% a year, rectal cancer is down. We've been doing a great job, 3% per year since the 1970s. So that's why when you look at the national statistics, we have 1/3 less people dying from colon cancer. It's amazing, and many fewer people getting colon cancer. So I think we've made tons of improvement. The incidence, however, which has been pushed down, unfortunately has not been pushed down under the age of 50 or between 50 and 55. Now, you'd say, why between 50 and 55? We believe that's a communication issue where people are getting the message at 50 and not receiving their screening for some time afterwards, 5 to 7 years on average. But there clearly is a significant bump and trend to people under the age of 50, with the greatest increase, although the lowest numbers, happening in the 20 to 30 range, the 30 to 40 range next, and the 40 to 50 range. So the rate of increase in those ages is a little deceptive, because when you look at colon cancer under 50, it's pretty significant. Over 50, you get rates in the 200 per 100,000 population. What we're talking about in the under 50 is more like 20 per 100,000. So almost a complete logarithmic difference, but a dramatic increase compared to what we had previously seen. And this is a great graph that shows this, if you want to pop in on this. And again, this is the shoulder that we're talking about right here, and it's in this box. And you see how dramatically this has risen up. This used to be a rather straight curve, and colon cancer was really a disease in the late 60s or 70s. So again, a dramatic increase. And let's just keep it on here for a while. So the incidence trends, if you're over 50, look how great we've been doing with men and women. Women have a little less colorectal cancer than men, but both of them, dramatic improvements over time. But when you look over on this side, between 20 and 49, you clearly see an increase. And in fact, since 1994, it's been almost a 51% increase over the last 15 to 20 years. So very dramatic, unequivocal. Again, look at the numbers here. This is 200 per 100,000. This is 20 per 100,000, right? So it's certainly not volume-wise as big of an issue. But this curve, unfortunately, is going to persist into the future. Just imagine a wave that it's coming up. You know, maybe small at this point, but how's that going to affect the future? Subsite distribution. Again, when you talk about people who are over 50, about a third of the colorectal cancer is proximal, and about a third is distal. But when you come over here, and about a third is rectal. But when you come over here to the younger population, this green are the percentage of people who have rectal cancer, and in terms of the distal cancer, it makes up over 50% of the colon cancer in young people is either in the rectum or distal colon, and that's as opposed to about a third or a quarter. So it's clearly separating itself from regular colorectal cancer, and again, that raises issues to what's going on with the exosome or the microbiome or something that's intrinsic to the colon in terms of why is it affecting that last part so much more in younger people. We don't know the answer to that yet. The trends by anatomic side, again, proximal colon is relatively stable. Distal colon is up 2.1% annually since 1994, but our real rise has been in rectal cancer, which is up 2.7% every single year since 1991. So that's 2.2. So really we're up, that's why we're up 50% in this disease overall. So it's very dramatic. In terms of stage, younger people tend to be diagnosed with more advanced stages of diagnosis. In the blue, you'll see localized cancer. In the red, regional. And in the green, distant or metastatic disease. Again, suggesting that these were not diagnosed through a screening or prevention modality, but diagnosed because of symptom presentation. And you can see the increase has gone up in this green, which is the metastatic disease, fairly significantly, 3.6 and 3.0% annually. And again, 3% in a year would be a lot, but 3% year after year after year after year really adds up. So we're diagnosing these cancers late, unlike the trends that are going on over age 50, where we're diagnosing more and more cancers early because of the beneficial effects of screening. In terms of 10-year age group, as I said earlier when we started, the majority, 75% of people with under age 50 colon cancer are diagnosed between 40 and 49. And so that's been going up 1.9% annually, whereas if you look at the lowest per 100,000, the 20 to 29, that's been going up even more dramatically at 3.8% annually, but again, a relatively small number. So I think the key thing here is that there's a sweet spot, if you will, in this 40 to 49 region where it encompasses 75% of the people under age 50, which will bring us back eventually to our recommendations about when we should start talking to people and when we should start providing screening options. Race and ethnicity, we are basically seeing stability in Asian Pacific Islanders and non-Hispanic blacks. However, in Hispanics and non-Hispanic whites, this trend is up significantly. That being said, non-Hispanic blacks have traditionally had the highest rates of colorectal cancer, so really we're moving up toward that incidence and such. So, but again, it affects all age groups, and so this is not, there's really no way to sort out, now that we know people's genetics are all mixed up when we do their 23andMe's, we need that opportunity to get this message out to all people. And this is fascinating because this really speaks to our policy for on-time information. If you look at what's happening on the left part of your slide, between 50 and 54, there's been a very, for colorectal cancer, there's been a very small, almost stable increase in colon cancer, whereas for the 50 to 59 age group, in other words, people who've been getting the message for 5 years, we've seen a dramatic reduction, 2.7% annually. In the rectum, it's similar once again. We've seen a decline in rectal cancer, not quite as great, 0.8%, but a rising annual rate between 50 and 4. So clearly our message to the 50 to 54 crew is not getting acted upon. Otherwise, we would see more screening. Or, alternatively, this could be that effective early age onset colon cancer that's moved into the 55 range, because we do think there's something that's happened to our population, so what's called a birth cohort. And we don't know what that is, but clearly it takes at least 5 years to get the message out, to get people screened, to result in a reduction. It's a challenge to figure out how we're going to better communicate, and we'll have some proposals towards the end of the talk. Finally, as I said, stage distribution. Early age onset here in the blue is not diagnosed early in very many occasions, whereas whether it's regional or distant or metastatic, younger people tend to be diagnosed with more advanced disease because they're not involved or enrolled in a screening program. Most of these folks are getting diagnosed because of symptom presentation, which we already know in the over 50 population is a bad prognostic indicator. 5-year survival, however, is great. Every single stage, whether it's early, regional, or advanced, younger people do better with therapy. And a lot of that is because I think they have a better performance status, they're healthier, they're stronger, they can tolerate surgeries, liver resections, more intensive chemotherapy. There's a higher percentage of these tumors which are microsatellite unstable, which means they have other options for therapy, such as checkpoint inhibitor therapy. But we do better, even though we get diagnosed with more advanced disease. So you can only imagine what we can potentially do if we can begin to either prevent these cancers or to diagnose them in the asymptomatic early stage in terms of improving survival. And finally, mortality rates here. What we're talking about here is this trend, and this slide is probably above my pay grade, but it demonstrates this birth cohort effect that's going on. So somewhere around the 1990s, rather than this trend going downward as we've seen previously, people born after 1990, this trend in colorectal cancer is actually increasing. And again, these curves are not that dramatic, but when you look at 340 million people in large populations, it results in a significant number of lives and everything like that. So again, flat trends in the 20 to 49, falling trends in the 50 plus age group, but not so much falling in the first 5 years, as we've discussed. This is not an American problem. This is a first world problem. So we're seeing this in Europe. We're seeing this in England. We're seeing this every place where first world issues and screening is available. So this is not a singular place. Canada, the United Kingdom, Australia, all seeing it. And here's by incidence by age. Again, unfortunately, Kentucky here in the over 50 age group. We know we're number one still in incidence in the nation. But again, a lot of that is now attributable to early stage 1 and 2 cancers found at screening, which we're finding this year, not 3 or 4 years from now. But in the under 50 age group here, we, along with our partner in crime, West Virginia, the Southern Cancer Belt, including Mississippi, Louisiana, Alabama, Oklahoma, are all, as well as Alaska, all in the black zone or the dark zone, as I would say. So lots of opportunity for improvement in the southeastern United States and in the Rust Belt. But again, there is variation, and certainly we know part of our issues in Kentucky are related to this early onset piece. So why does it occur? And we're going to back up on this. What we do know is that about 50% of people under the age of 50 either have a genetic or a familial predisposition, either a first-degree relative or multiple second-degree relatives, or an actual genetic syndrome. So that's really high. So 50% of folks under 50, we've got some clue, and as long as we get to that person in time and get that screening performed on time, we could be preventing, I think, up to 50% of the under age 50 colorectal cancer just on the basis of changing the timing of our message to find a way to impact them. The other 50% of these under 50 folks are sporadic colon cancers that we don't know where they're coming from or why. And that's more difficult because that's more information about generalized healthy lifestyle and making people aware of their body and knowing what to do when they have symptom development. But some things that have been proposed. So again, 50% of this is genetic and familial, and we have the tools today if we can learn to deliver an activating message on time. But in terms of environmental issues in the exosome, there have been talks about the effect of the microbiome, particularly glyphosate, which alters the microbiome. That's Roundup. High fructose corn syrup. So, things in beer, processing. I always tell people every time you drink out of a styrofoam cup and you smell the styrofoam, those are styrofoam molecules that are getting into your nose and probably into your mouth and your gastrointestinal tract. Every time you get into a hot car in the summer and it smells like vinyl, that's because the vinyl is aerosolized and it's in the air. So there's no one single thing. Obesity, oxidative stress, tobacco. Many of the folks with early age onset colon cancer don't fit our picture of colon cancer folks. These are healthy people who run marathons, who eat properly. So the usual risk factors we attribute to folks as they're older don't necessarily apply. So this is probably, a lot of it's the same disease, but certainly not all of it. And many of the people who we work with at the project, they were far and away from unhealthy people when they got their colon cancer. In fact, they tend to be just the opposite, super healthy people. So we don't know the answer yet. And is there a birth cohort family? I don't know who puts their kids in 5-gallon buckets, but we do know that starting around 1990 in the late 80s and 90, something happened that is felt, whether it was something that happened in utero or that happened after birth, or that happened as a change of our diet or nutrition or environment. We don't know the answer, but it's there and it's real. So for people who are over the age of 50, sporadic cancer makes up 75% of the cancer. In other words, only 25% of it is hereditary or genetic in nature. However, when you look at young onset, and this is under 35 to make a point, again, 50% of the cancer is sporadic and 50% is familial or genetic. And so this is a one wedge opportunity we have to really make a difference. And part of this goes back to identifying family history on time, which again is usually at least 10 years prior to that family member or first-degree relative developing their problem, or if they're older, starting that conversation at age no later than age 40. There's a couple of genetic syndromes that are rare. Familial polyposis, where people develop thousands of polyps. Again, autosomal dominant. Cancer risk is 100%. These families are usually quite well known. There is a condition called attenuated familial polyposis, same genetic abnormality, but where people only present with tens or dozens of polyps over their lifetime. And that's why people with 10 or more adenomatous polyps in their lifetime probably should undergo genetic screening to make sure they don't have an attenuated form or another type of polyposis. Lynch syndrome is the one we talk about all the time, but it only represents about 3% of colorectal cancers. It's also autosomal dominant, meaning it only takes one copy of one gene. It tends to be early onset with an average age of 44, but about 46% of people get diagnosed after the age of 50. So not thinking about Lynch syndrome in the over 50 population is a frequent clinical mistake, because you just think, well, it wasn't that early. But Lynch syndrome diagnoses occur into the 60s and even the 70s in people. It tends to be a proximal cancer versus what we've talked about, the traditional younger colorectal cancer being right-sided. And these folks get multiple other cancers: gastric cancer, pancreatic, small bowel, kidney, biliary tract cancer, brain tumors, and certain types of skin tumors. So it usually is a syndrome, and you would think with such a dramatic presentation we'd find it, but in fact we estimate that we only diagnose 1 out of 10 patients with Lynch syndrome. And that's really that's an area that clearly cries out to how do we do a better job of talking about family history and family history associated risk. But these are tricky. Not every person with Lynch syndrome gets colon. Some people get ovarian. Sometimes they get endometrial. It may skip a generation because these genes don't always cause cancer. They just most commonly cause cancer. Once we identify them, we usually do annual colonoscopies starting at age 25 or 10 years earlier than the youngest member. Most of the time we do not do prophylactic surgeries and such because, again, only 80% of people get colon cancer. But it clearly being in a center of expertise where someone can help manage your risks, and again, not just your colon risk, but your other wide body risk is important. This is just a slide that demonstrates this curve. Over here on your right are these normal colon cancer trends. So it begins to be a disease out in the 70s or the late 60s. And Lynch syndrome here with the fluorescent green is shifted over to the left and peaks around 44. But again, a substantial percentage of people bridging that 50-year-old gap. So it's a matter of being aware of it and looking for it. This just as a little note, we wrote a paper in 2014 in the Mayo Clinic's Proceedings that sort of talked about this. So this, what are we, 4 years past that? We've been talking about the importance of this and the awareness of it for some time. A lot of great co-authors, and I'd recommend any of the papers by Dennis Anand, who's at the University of Colorado, a great scientist and great physician who's been passionate about this for years. But if you want to look about where we were and what's going on now, this is an excellent source. So we're going to shift over and talk about delays in diagnosis. Those are the tragedies we hear all the time when we go to conferences and people tell their stories. It's almost invariable. There's about a 6-month delay in diagnosis because there's a lot of GI diseases that are common: irritable bowel syndrome, hemorrhoids, stress, anxiety, bad diet, etc., that can mimic colon cancer because there's a lot of overlap: abdominal discomfort, bloating, change in bowel habits, intermittent rectal bleeding. In retrospect, it's all easy to call it colon cancer, but when you're a young person and colon cancer is not on your radar in terms of something that it could be, frequently, I say the average is about 6 months before that person who has symptoms actually goes to a doctor to ask about their problems. So that's delay number 1. And again, this is related to low awareness of the early age onset factor and the commonality of internal hemorrhoids and IBS. Also, symptoms come and go, right? And then once people see a physician, physicians are not educated to the degree they need to be. And many times we'll treat this as irritable bowel syndrome, internal hemorrhoids, and delay diagnosis in up to a third of patients. So it's incredibly important that we begin to educate providers as well that it's not irritable bowel and hemorrhoids until the colonoscopy and the diagnostic testing has been completed. Then it's irritable bowel and hemorrhoids. Till then, with this dramatic increase, it's going to be colon cancer until proven otherwise. And again, sometimes it's reluctant to proceed to colonoscopy, but we've all been taught on older algorithms from the 70s and 80s and 90s and 100s. So this new early age onset is important. And finally, I can't emphasize the importance of the fact that we as physicians and healthcare providers do an extremely poor job of collecting family history throughout life. Family history is the key to genetic disease and familial disease. Yet there's poor communication between parents and what kind of polyps they had or did not have, cancers they had or didn't have, with that information not going by computers or electronic health means to then prompt the children or the relatives in some form or fashion to take action with a particular screening test or a particular screening program. And so we know that in many places, family histories are only used accurately between 5 and 20%. And that's really, we all thought the computers were going to help us. And in fact, I think the computers have really gotten in the way of it because we do a poor job. We click the boxes. Only very few institutions are doing aggressive excellent family histories on a regular basis, and then linking that to testing. And that's the key, because if you have a family history that hangs out there and you don't do anything about it, it's the same as not having taken one in the first place. So these are things we already know, right? We already know that if you have cancer or adenomas in a first-degree relative, particularly advanced adenomas, you should begin at age 40. So we're going to have to talk to people about their family risk before the age of 40. And the more I've thought about it, I really think 35 is the age, because if you're old enough to be the president, you're old enough to manage your risk about colorectal cancer, understand your family risk, and have some lead time to be able to make the connection. And we already know it takes about 5 years for people to get the message from the time we start till the time they act. So it doesn't have to be 35. I thought that's always good. That was the age I quit smoking. You don't have to put that on there. But I did it because I thought I was old enough to be the president. Gonna have some fun, right? This isn't for everything. And obviously if you have colon cancer in greater than 2 second-degree relatives, and that would be your grandparents or your aunts and uncles, also to start at 40 years. So unless I have a general rule. I don't want new rules until we're already following the ones we have. And these rules are in the books, widely evidence-based, and we've got to find a way to operationalize a communication strategy or an information strategy to connect the 20% of people who fit this category. So it's not 2% of people, it's 20% of people. So this is about 50% of the early age onset colorectal cancer that we already have the tools for, but we're not implementing because we haven't connected the dots back. All right, so we're talking about essentially avoiding the deadly pitfalls. Okay, and we talked about the fact that we already have great guidelines and recommendations. We think the issue is that we're not getting information out to people early enough so they can act on it. Likewise, with regards to genetic and family history, this is a genetics testing panel. And again, most genetic testing now is done by multi-gene cancer panels that look at a variety of issues. But it's important because breast, ovarian, endometrial, gynecologic cancer overlaps with gastrointestinal, particularly colorectal cancer, to the degree that if you don't identify an accurate family history and then recommend appropriate genetic testing if they meet evidence-based criteria, you have the potential to miss this genetic syndrome. And 16%, according to Heather Hampel's data from Ohio, have a genetic syndrome under the age of 50. But what's fascinating is half of those are GI cancer syndromes, genetic syndromes, and the other half are non-GI, particularly a large component of people with breast and colorectal cancer, BRCA1, BRCA2, and CHEK2. So this technology is coming our way. It is extremely accessible. Price is going down, unfortunately, amongst providers, institutions, hospitals, etc. There's not widespread utilization yet. But this is the future of cancer prevention and genetic testing for sure. And again, back to Heather Hampel's data, 1 out of 6 had a genetic mutation under the age of 50. Half of those were Lynch syndrome, the other half were not Lynch syndrome. And so her conclusion that genetic counseling and broad multi-gene panel testing should be considered for all patients under the age of 50, regardless of their family history or their MMR status, which is a mismatch repair issue, which is a genetic piece that's really beyond the talk of this. But it's how we used to diagnose who did or didn't have Lynch syndrome. But the genetic testing paradigm is going to shift where people are going to get a genome testing and a mismatch repair evaluation rather than immunohistochemical testing and everything else. It's going to become frontline therapy. But again, if you don't get this information in advance and you only make the diagnosis with genetics after a cancer is developed, we've lost the real power and the benefit of genetic testing. Finally, what can we do? I was in Iowa recently, and we've had a lot of storms around the country. You do not have to be a meteorologist to know how to get out of a hailstorm. And really, we have a hailstorm with regards to early age onset colon cancer and also adverse effects in the 50 to 54 range. And so we know this. Yes, we don't know why. We're not sure of the biological factors, We do know that 50% of it can be addressed with better communication strategy at an earlier age to those folks, but we don't have to understand it completely to begin to tell people how to avoid the known familial risk factors as well as identify symptoms of sporadic colon cancer. But again, here we go. First degree relatives greater than 50, we're doing a pretty good job, 75%. But the first degree relatives who are between 40 and 49, and other ones, the ones that should have been screened, we're screening only maybe 38, 40% of those. These are the highest risk individuals in our whole population, yet our screening rates are lower than the normal average risk person. We want these folks who have first degree relatives to be above the average, not below it. And that should be our big, hairy, audacious goal going forward. Again, people under the age of 50, 40 to 49, who've ever had a diagnostic or a routine endoscopy. 2013, it was only 10%. Okay, so there's some disparity between these studies, but they're low. We want people to undergo appropriate screening at the right time, and we're losing out. Hereditary cancer risk assessment. We need a protocol. Your office ought to have a protocol for finding people who are at risk and then offering appropriate genetic testing, because you can't tell which one of these orange fish has a familial risk or which one have a genetic risk until you test them. And you have to have a process for not only identifying them, but in fact testing them. A simple family history questionnaire is appropriate. There's a variety of these are available through a variety of genetics testing companies. So the important thing is we know about BRCA, we know about Lynch, but we can't escape that we're only diagnosing 10% of those syndromes, and it's because of a lack of an accurate family history. Part of this issue is that people have low rates of pickup going to genetic counselors. You can have a dropout rate in this slide between 30 and 70%. So that means 2 out of 3 people in most cases that you refer for genetic counseling aren't going to get the test. And so point of service testing is going to be the next phase where doctors can identify risk based upon an algorithm and then do the testing right there. And then hopefully that'll reduce that dropout rate dramatically. So some of the issues that we've been working at home on the project are actually, how do we really expand the continuum of colon cancer prevention? Because we've really focused on get screened at 50 and beyond, and we've had some excellent results after age 55, but we clearly are dealing with 2 issues. Number one, our communication strategy is not working between 40 and 55, and likewise, people who do not have family histories, who are developing sporadic cancers, are unaware of the increasing incidence and so don't know to act immediately on those symptoms in order to get earlier diagnosis. So we've proposed a prevent colon cancer throughout your life, including many issues: diet, nutrition, exercise, not smoking, maintaining a normal weight, all which are evidence-based American Cancer Society guideline issues, but we tend not to talk about it with regards to colon cancer. Secondly, understanding your family history a little more in depth and dramatically than we had in the past in terms of getting that information on time. Again, we think starting at 35 so we can catch that risk, that group of people who are at risk and need to be done at 40, and also understand those folks who are at risk for genetic syndromes. Genetic testing when appropriate, high-risk conditions such as Crohn's or ulcerative colitis. And by 40 or 35, a hard stop on information. Both to the providers, but also to the patients, direct to the consumers. Because, again, a lot of men, in particular, is my biggest puzzle. They don't have doctors. They don't have doctors in their 20s. They don't have them in their 30s, and many times they don't have them in the 40s. So we have to find a way to reach those folks that isn't going to be through traditional communication methods. Maybe it's their cell phone. Maybe it's ESPN, digital media. Who knows? We're not aware that that's where the new lines of study in terms of communication and marketing need to be. We do know, however, that if we want to find people who need to be screened at 40, and that's about anywhere between 15 and 20% of the population, we have got to message those people, noted here in the red marks, in advance of that. Now, how deep the message needs to be, how strong the message needs to be, what's the frequency of the message, I think that all needs to be sorted out, studied, and bring in expertise in the field. However, unequivocally, the timing of the message needs to be ahead of the event that you're trying to get performed. And so we've been focused on the above 50 message And I think our statistics suggest and show that we've been ineffective in the early age onset known risk group folks, and we've been ineffective in the 50 to 54 age group brain, because it takes people about 5 years to warm up to the idea of having a long 6-foot black tube in their bottom, or fecal testing, or any kind of poop related piece. We've demystified it a ton, but not all the way. And so we've gone from the current message package here, which is your 50 get screened, which is, again, we'd never tell our children to start thinking about it the day it was due. We teach them all the time to think ahead of it. And we've moved to where we're talking about the on-time date and the on-time options. But really, we begin to, again, just talk about prevention and screening with testing. The important issue, though, is that we're leaving out the people who have sporadic cancer, and we're also leaving out people who have family genetic histories, as well as people who have the opportunity to prevent colon cancer by lifestyle changes. So we're proposing this additional piece called the early message package, whereby we combine in a message to folks when they're younger, in their 20s and 30s, about how you prevent colon cancer: smoking, diet, nutrition, exercise. How you recognize the symptoms of early onset colon cancer: diarrhea, change in bowel habits, unexplained weight loss. If they don't know those are symptoms of colon cancer and they need to be checked, we're not doing a good job of educating our folks. And then finally, really honing in on the importance of the family history piece. Do you have a genetic piece? Do you have a familial risk? Using that information to then link it to an action, whether that be screening with appropriate studies or genetic testing. It'll all depend upon what the history is and everything else. So I always have this slide last. This is a picture about what my son drew. This is a man who has a boulder in front of him, and the only thing that man can't do is move that boulder, and he has no arms as well, but he can walk around that boulder. He can get a bulldozer. He can blow it up. He can get friends. You can't just focus on what you cannot do. And so our goal at the project is to take what we think we can do with regards to early age onset colon cancer, not knowing everything and having incomplete knowledge, which is, by the way, is part of being a doctor. You have to act on incomplete knowledge, quite frankly, frequently, and begin to do something that we know is going to have an effect. And we think the most important thing of that is giving information out in a timely fashion that is evidence-based and leads towards actionable work to prevent colon cancer. Thank you very much, guys.